Hello and welcome to our Flash Note series. In this series of lectures, we are going to discuss on very high-yield clinical concepts with their proper clinical correlations. This is Flash Note 5. In this particular Flash Note, we are going to discuss on nerve injury. So let's discuss about what happens when there is peripheral nerve damage. This is a type of nerve damage that can occur secondary to trauma and commonly affects the nerves of arms and legs. There is a world classification scheme that is still used to describe the nerve lesions, and by this scheme, a mild nerve lesion is called neuropraxia, a moderate nerve lesion is called axonotmesis, and a severe nerve lesion is called neurotmesis. But whatever be the lesion, the result is there will be weakness or sensory loss. And in order to understand the different degrees of peripheral nerve damage, we can use this illustration to define the types of lesion. So the deep inside here is a neuron that is running all over the length. It's a segment of the axon, and of course here will be a cell body, and here will be the telodendria structures, and it's myelinated structures, and this neuron is covered by endoneurium. The bundles of fasciculi of the neurons will be covered by perineurium, and the nerves will be covered by epineurium. So this is the basic concept of organization of a neuron. So let's enter into the basic two extremes of the neuron damage. So first, the most common and it's mild injury is the neuropraxia. In neuropraxia, there will be only the sites of focal demyelination. Here in the figure, we can see this bluish, that is the myelin sheath, and there is only the focal demyelination of this myelin sheath. It can be seen in case of the neuron compression. That's in case of the wrist drop. The myelin sheath of the radial nerve gets compressed, and there will be the phenomenon called the wrist drops. So this is a classical example of neuropraxia, and there it has the excellent prognosis as well. But the other extreme end is that the neurotmesis. In the neurotmesis, there is a loss of continuity of all these structures of this neuron. So this is the having worst prognosis at all, and there is no significant regeneration. So what we need to compare and contrast between neuropraxia and neurotmesis is that neuropraxia is having the best prognosis because only the focal demyelination of the neuron is taking place. But in case of the having worse prognosis because it's having a severe lesion, and the axon as well as myelin sheath are getting irreversibly damaged. So this is the classical extremes of the peripheral nerve lesion, and in between of them too there is a moderate nerve lesion that is known as axonotmesis. In axonotmesis, there is a demyelination. Here in the figure we can see a demyelination, as well as there will be the damage to the axon. So also the axon is being damaged. So the classical combination of demyelination as well as damage to the axon, and all other structures like epineurium, endoneurium, perineurium, they remain intact. So in axonotmesis, it's something different than neuropraxia and neurotmesis. Here there are two different sets of event distal to the site of lesion and proximal towards the site of lesion. So let's see what are these two different events. So proximal to the lesion, there will be the axonal reaction. So axonal reaction is also known as a central chromatolysis. The main feature is that in response to the neuronal damage, the maintenance machinery of the cell body gets activated, and there will be increase in the protein synthesis of the cells for repair. And one of the most common changes that can be seen is the changes in the cell body. So here in the figure, we can see the change in this cell body and this cell body. So larger cell body is the cell body of a damaged neuron, whereas the normal looking cell body is cell body of normal neuron. So the first thing that we can differentiate between these two is that in case of the damaged cell body, central Naegele's granules which are normally present in case of cell body, they are being lost. Other changes like cell is losing its sodium potassium ATPase, which are ATP dependent, and because of loss of this ATP dependent sodium potassium ATPase, the cell is accumulating more amount of sodium, and in response to accumulation of sodium, there will be the hydropic changes like a cell is swelling up. And other features like the nucleus of the cell. Here in the picture we can visualize the nucleus of the cell that has been displaced towards the periphery. So three particular changes, that is first hydrophobic change or swelling of the cell body, second chromatolysis, that is disappearance of Nigel's granules, and third nucleus displacing towards periphery. And the combination of these three signs, it's called the axonal reaction. So this is one of the very high yield point. Axonal reaction is always seen proximal to the lesion, and the other reaction that can be seen is distal to the lesion, that is Wallerian degeneration. So distal to the lesion, there will be first phase 1 where there is an acute response to injury, and there are phase 2, there will be the activation of the cytokines, nerve growth factors, chemokines, and other particular hormones. And in the phase 3 there will be the execution of the Wallerian degeneration, and the Schwann cells, if they are intact, there will be the regeneration of axon, and if the Schwann cells are also lost, then there will be the formation of myelin debris. So this particular slide is a very high yield slide because it contains two types of reaction that can be seen in case of axonotmesis. So what must be clear is that in case of axonotmesis proximal to the lesion, there will be the axonal reaction which can be visualized with the chromatolysis and nucleus moving towards the periphery. So in our examination, what kind of question is asked is that they will just give us the basic hint about the cell body swelling. Like they will tell us in experimental study it has been found that some of the peripheral neurons is having the signs of chromatolysis. They won't directly tell us it's having chromatolysis. They will tell us that there is no appearance of Nigel's granules, and they will tell us that the on microscopic examination the nucleus has been moved towards periphery. Then with this particular hint we must be able to catch the idea that they are asking us about axonal reaction. So this is a very high yield slide. And regarding Wallerian degeneration, they can call us that after a certain time there is a formation of myelin debris, which are actually formed by the Schwann cells, which degrades the myelin sheath. So they can give us the particular hint like there is the formation of myelin debris. Then what kind of reaction is this? Then at that time we need to be clear that they are asking us about Wallerian degeneration. So axonal reaction and Wallerian degeneration, they are very high yield point. Regarding other changes on the central nervous system, so the neurons of the central nervous system, they are very highly susceptible to ischemia and hypoxia. Mainly after 4 to 5 minutes of ischemia, there are certain cells within the central nervous system which are very sensitive to hypoxic changes. So mainly cells in hippocampus, they are most vulnerable to the ischemia, mainly because of the two reasons. First reason, they are having very high demand for energy. Second reason, that they lack the glycogen storage. So we need to understand, or we need to memorize some of the very sensitive neurons. So compared with glial cells, neuron cells are more susceptible to damage, but among the neurons as well, there are certain neurons which are more vulnerable to hypoxia, just like hippocampus, which cannot resist hypoxia for more than 3 minutes. And in case of like neocortex in the Purkinje cells of cerebellum, they can resist hypoxia for around 10 minutes as well. So we need to understand that there are certain neurons which are having very sensitive towards the hypoxia. That's why I have mentioned mnemonics here, like starving hippos needs pure water. You can memorize it later on, like striatum cells in basal ganglia, hippocampus, neocortex, cerebellum, watershed area between the ACA, MCA, and PCA. That's also very high point. I know what kind of question will be asked is that suppose a person suffers from cardiogenic shock, and he comes to hospital after around 10 minutes or after half an hour. So half an hour or even 10 minutes is enough time for the damage to central nervous system. So which cell of the central nervous system, which particular neuron of the central nervous system will get affected? So this kind of question can be expected in our step exams. So in response to ischemia, it follows a particular pattern. So a particular sequence of event can be predicted in response to ischemia, just like within 12 hours there won't be any microscopic changes within these ischemic cells, but after 12 to 24 hours there are certain changes, and following that time there will be other changes as well. So after 12 hours there will be formation of the neurons called the red neurons. So red neurons are nothing but the dying neurons. Of course the dying neuron will lack nucleus. That's why there won't be any areas of basophilia. So in a red neuron or darkly eosinophilic patches can be seen. So all these red spots are the red neurons, and they are manifested only after 12 hours of ischemia. So up to 12 hours, no any changes. After 12 hours, up to 24 hours, there will be the appearance of red neurons. And the appearance of red neurons, this is a very high yield point. So what kind of question can be expected is that suppose a person is brought to hospital, and so despite of any aggressive measures, the person dies, and upon autopsy there are certain changes, like there are intensely eosinophilic cells are seen upon biopsy, and there are loss of Nijers granules as well. So loss of Nijers granules and the presence of intensely eosinophilic cells, so they are like giving a hint, like they found out red neurons upon autopsy. So and what kind of question they can ask is that what time has been there from the inciting event of the ischemia. So from the appearance of red neurons, we can suspect that the it has been around 12 hours, but not more than 24 hours of the inciting event. So this one is also very particularly very high yield slide. So regarding other changes from 24 to 48 hours, the most visible change is that there will be the liquefactive necrosis. So we need to understand the pathophysiology of liquefactive necrosis. Liquefactive necrosis proceeds with the lysosomal enzyme release, and they can occur only after 24 to 48 hours. And regarding other time, like from days to weeks, there will be the formation of cyst, and this cyst is formed to wall of the sites of necrotic zone. And this cyst, suppose this is the cyst, this cyst is actually formed by the astrocyte cells. The astrocyte cells, which forms the blood brain barrier, actually forms this cyst. And the main physiology of formation of cyst is that the cytoplasmic processes of the astrocyte cells, they form extensions around this damaged debris of cells, and they will form the wall that is known as the also known as the gliosis. Gliosis is simply just the multiplication and enlargement of the cytoplasmic extensions of the astrocyte cells. So this is also particular high yield point, because they can present us the scenario like a person is presenting to your hospital, but he has a transient ischemic attack 4 months back or 5 months back, and now he is having a second attack, and despite of any aggressive treatment, he dies. And upon autopsy, we can see a layer of cyst around his brain. So here in the picture, we can see a layer of cyst around the brain. So they can ask us the question that what will be the wall of this cyst made up of. So this is a very high point. We need to understand that the wall of the cyst is made up of the astrocyte cytoplasmic extension. So this is a very high point. Although we know that the normal brain parenchyma are covered by pia mater, these cyst layers are not covered by pia mater. These are particularly covered by the cytoplasmic extension of astrocyte because of gliosis. This is a very high slide. So regarding the imaging, suppose a person appears to your clinic, is having suspected stroke. So the first imaging you will call is non-contrast CAT scan of head, but you will do non-contrast CT scan of head only if the patient is symptomatic. So if the patient is asymptomatic, like a person has just had a transient ischemic attack and is asymptomatic at all, let's say he got resolved of his symptoms, now you have to do further investigation. So you need to think about doing diffusion weighted imaging of MRI. So DWI MRI carries more sensitivity in detecting ischemia within 3 to 30 minutes, but the CAT scan of the head, it can detect ischemic changes only after 6 to 24 hours. Here I will compare two images. So in the first image you can see a CAT scan of the head, but this is a very normal looking CAT scan. Here the almost all the white matters and gray matters are well differentiated, but in but the DWI image of the same patient has been done, and it shows the wide area of stroke on the middle cerebral artery, which was not initially visible on CAT scan. So you need to think about the sensitivity and preferring DWI in compared to CAT scan of the head if you have enough time. But if you are short of time, then you can go for CAT scan. So the first modality you will recall is CAT scan, but if you have enough time, then you can go for DWI images. So regarding the summary slide, I have made a spectrum of changes, and it includes all the points which I have already stated, like change between 1 day. Changes can be predicted. So 1 day, within 1 day, for the first 12 hours there won't be any change, but after 12 hours to 24 hours there will be eosinophilic cytoplasm, and there will be a pyknotic nucleus with the formation of red neurons. And from 1 day to 1 week there will be the both activation of neutrophils at first, and after around 72 hours there will be the macrophages starts to get activated, and mainly the microglial cells, which are stem cells, monocyte origins, they get activated. And after weeks to month there will be the formation of reactive glycolysis from the astrocyte cells, and also there will be the sites of new vascularization that you need to care of. So with this we are entering into an answer discussion. So here a 65 years old man comes to emergency department with a right upper and lower extremity weakness and slurred speech. So the signs of right upper and lower extremity, both upper extremity as well as lower extremity weakness and slurred speech, that's the aphasia. It's something indicative regarding the internal capsule. And so his right extremities are being affected. It means that he might have lesions on his left side of his brain. So the patient went to bed in his usual state of health and woke up with the symptoms. So he was in bed with his normal health, but when he woke up he was having these neurological deficits, and his medical problems include he is having type 2 DM, hypertension and hyperlipidemia. He takes these medications and has smoked a pack of cigarette for the past 40. And now what we have seen is that he is having uncontrolled hypertension. So despite of all these medications, his hypertension is still uncontrolled. Physical examination, he was being mildly dysarthric. It means he was not being able to articulate his words with a right lower facial droop and right sided hemiparesis. So all these lesions are seen in the right side of the manifested in the right side of the body, and on anxiety head it's normal. So we have recently seen that non-contrast CT scan of the is not that accurate in case of the acute infarction or acute ischemia, and upon brain MRI here we can see acute subcortical infarction in the left internal capsule. So because of lesions on left internal capsule, so he might be because of hypertension and type 2 DM, he might be having hyaline arteriosclerosis, and because of this hyaline arteriosclerosis he might be having like a lacunal infarction of the brain. And this lacunal infarction of the brain is mainly because of the infarction of the lenticulostriate arteries, which are supplying these internal capsules of the brain. And lenticulostriate artery are the branches of the middle cerebral artery. So it's not that much about the information we need for this question. So what has been asked is that after 6 months, which of the following findings is most likely to be observed in the affected pyramidal tract of the patient? It has been indicated that certain axon has been damaged. Because of that damage to the axon, it has resulted in the axonal degeneration, and the myelin sheath has been degraded because of that axonal damage. And of course after around 6 months we can see the debris of myelin sheath. So I have already mentioned in our Wallerian degeneration slide. So it will be the persistent myelin debris that will be seen after 6 months. Next question. The anterior horn cells of the spinal cord of an experimental animal demonstrates cell body rounding and peripheral displacing of nuclei and dispersion of nasal substances to the periphery of the cell. So it's just like there is a large nucleus, and there is the displacement, peripheral displacement of the dispersion of the nasal granules, and the nucleus has been shifted to one side of the cell. So this is the classical reaction that can be seen in case of the peripheral nerve damage. Sometimes axon becomes severe due to trauma, and such injury causes specific changes in both proximal as well as distal segment of the axon, as well as in the neuronal cell body. The degeneration of the proximal segments extends to the closest node of Ranvier, and the changes seen in the neuronal cell body after the axon is severe are called the axonal reaction. The first sign is cell body shows the signs of cellular edema, and it becomes swollen and rounded with the nucleus displaced towards the periphery. Nasal granules becomes fine and granule, and they get dispersed throughout the cytoplasm. That is known as a central chromatolysis. So this is the classical example of axonal reaction. So our answer is of course axonal reaction. Next question. So here our researcher is studying neuronal changes in various physiological and pathological states. The microscopic examination of the neural tissue obtained from experimental animals shows neurons with shrunken nuclei and eosinophilic cytoplasm lacking Niger's granules. Indicates that they are showing something about the red neurons. So it is something like the neurons has been damaged for more than 12 hours. So our classical answer will be irreversible ischemic injury. So they are giving us the hint regarding red neurons. Here in the picture I have summarized the response to the nerve injury. Now let's enter into fourth question. 63 years old man collapses at home after experiencing severe restaurant chest pain, and the emergency medical team finds him with no pulse and cardiac monitor shows ventricular fibrillation. So he is having ventricular fibrillation and CPR is performed. The patient regains spontaneous circulation after several minutes, and on arrival to hospital he has stable signs but does not show any commands or response to a strong stimuli. So which of the following areas is most likely to be affected? First, by the ischemic damage in this patient. So of course we need to have sound knowledge on the very vulnerable sides to hypoxia in the brain. So this is about hippocampus. So I have already talked about the pyramidal cells of hippocampus. So the list goes like this: striatum in the basal ganglia, hippocampus, neocortex, cerebellum, Purkinje fibers, and watershed areas. These are the sites which are very vulnerable to damage in response to hypoxia. So let's enter into fifth question. Here it a question like an 82 years old man is found unresponsive by his neighbor, and the patient lives alone in his suburban home. When the neighbor went to check on him, the patient was on the floor and not answering any questions. His medical history is unknown. On arrival to emergency medical services, the patient is obtunded and responds only to painful stimuli, and supportive measures are begun including intratracheal intubation, but the patient dies en route to the hospital. Autopsy reveals extensive atherosclerotic disease involving the coronary and the internal carotid artery. Histopathological examination of the brain in the right middle cerebral artery territory shows the neurons with intensely eosinophilic cytoplasm and nuclear fragmentation. So intensely eosinophilic cytoplasm and the nuclear fragmentation, that's catarrhexis, is the classical features of the red neurons. So red neurons are always formed within 12 to 24 hours. The question that has been asked is that based on these findings, this patient's cerebral injury most likely occurred approximately how long ago? So our answer is 12 to 24 hours. This is going to be a very easy question. So here I have made a summary slide of the changes that can be seen after the certain hours of damage. Now next question is that here a 75 years old man is brought to emergency department due to 2 hours of left-sided chest pain and dyspnea. The patient has lived in a skilled nursing facility since developing right-sided hemiplasia, hemisensory loss, and aphasia 4 months ago. It means that he has a first event 4 months ago. Now he has the history of diabetes mellitus, hypertension, and hypercholesterolemia, and as the ECG is being obtained, the patient develops ventricular fibrillation and dies despite resuscitation events, and autopsy is performed. A coronal section of the brain is shown here. So here a coronal section of the brain is shown. So here in this coronal section we can see the cyst formation. So what question has been asked is that the walls of the brain lesion, so wall of this cyst are more likely composed of which of the following? Of course we know that the wall of the cyst are not composed of pia matter, but they are walled off by the cytoplasmic extensions from the astrocyte cells. So our answer must be astrocyte cells. Remember that the this gliosis is the event after 1 week to the events of month and year. So gliosis is what has been asked here with the cyst formation. Next question, the same image has been used. So a 70 years old woman with history of unilateral extremity and seizures is found unresponsive at home by her home healthcare nurse, and on arrival to emergency medical services found to have no pulse or any spontaneous respirations, and she is declared death. Autopsy shows large thrombus occluding the left anterior descending artery, coronary artery, and additional cerebral findings are shown. So which of the following most likely describes the pathogenesis of this patient's brain lesion? So it has something asked about the what kind of necrosis can be seen in the brain lesion. So our answer would be liquefactive necrosis in a straight term, but it has been asked something in a round of manner. That's why our answer must be tissue destruction by lysosomal enzymes. So this is the pathogenesis of liquefactive necrosis. Next question. Here, a 56 years old man dies in the hospital due to aspiration related complications. The patient was admitted 5 days ago. It means that his first event occurred 5 days ago with right-sided weakness, sensory loss, difficulty with speech and swallowing. CAT scan revealed the area of hypotensity in left frontoparietal region. So here in the CAT scan, we can see the lesion in the left frontoparietal region. An autopsy examination is performed and a section of the loose and spongy areas has been marked in the abnormal brain region. Histological findings after staining for lipids are shown below, and what question has been asked is that the cells most intensely stained in this patient's brain specimen represents which of the following cell types. So of course it has asked us about the event after the ischemia to cerebral blood vessel event that occurs between 1 day to 1 week. First is that there will be the activation of neutrophils. Second is that there will be the activation of the microglial cells. So microglial cells, they eat off or the phagocytose the large lipid droplets and they will form the foam cells. So here in the picture we can see foam cells right here. So our answer must be the microglial cells. So that cells which has stent deeply is the microglial cells. Last question. A researcher conducts a study to evaluate the morphological change in various cerebral pathologies using live animal models. In an experiment, histopathological examination of a brain after inciting event shows the neurons with intensely eosinophilic cytoplasm and condensed basophilic nuclei, and serial biopsies are obtained to evaluate progressive changes. Which of the following is most likely to be seen in the affected brain area? So of course this is about something about gliosis. The event which can be seen is the hyperplasia of the astrocyte cells forming the gliosis. So our answer is glial cell hyperplasia. With this we conclude our flash note. Stay tuned. Thank you.